Right. So one of the questions that more people missed is about a reflex. And the question was, a reflex can be defined as a relatively stereotyped movement or response elicited by a stimulus applied to the periphery, transmitted to the central nervous system, and then back to the periphery. Regarding reflexes, which of the following is true? And the answer, there was different options. The answer was the sensory neuron conducts nerve impulses along an afferent pathway toward the central nervous system. And basically, let me share my slides real quick, or share my screen. All right, can you guys see this now? So this is just an example of that reflex arc. So the question was kind of what pathway does the sensory neuron conduct the nerve impulse? And so it was here along the afferent pathway to the central nervous system. So that's the answer we were looking for. Another question was, which region of the brain regulates temperature, blood pressure, and heart rate? And this was my fault that I didn't catch this. The options, the answer was hypothalamus, but the other answers were thalamus, frontal lobe, and brainstem. And so brainstem kind of includes the hypothalamus. So I just made those two answers both be correct. And that pretty much included, and then everybody got it right. So that was just something I did not notice. And then the last one really was a hard question, but I kept it in there because 65% of people still got it right. And it was a good question. It was just hard. Says a 65-year-old male presented with back pain 2 days after he was shoveling snow. The patient complains of pain in his low back that radiates into his buttocks, posterior and lateral thigh and calf on the bottom of his foot, as well as associated numbness of his lateral and plantar surface of his foot. Which of the following disc herniations was the most was most likely affected? So it really just came down to kind of teasing through where the symptoms were and remembering your dermatome map. And so the answer was L5S1, because it was along the buttocks, the posterior thigh, buttocks, posterior and lateral thigh, calf, and the bottom of the foot. So that was L5S1. So it was just a hard one, but it felt fair because this is all information that you guys learned through your practicum as well. And it's still quite a few people got it right. So those are the only ones that honestly I wanted to go over. Everything else, everybody scored really well. There weren't any other questions that seemed like it was an issue with the question. So does anybody have any other questions from that exam? Okay.
Oh, I just had a question. Can you hear me?
Yes.
So posterior thigh or like lateral thigh would be L4, right? And then the lateral calf would be L5. So I don't remember what I really put, but I think that's what I was confused about.
Okay.
Was if it was posterior lateral thigh, then how would it be L5?
Posterior, so, I stopped sharing my screen. There we go. Okay, so posterior and lateral thigh. So S1 would be kind of posterior and L5 would be lateral.
Okay, okay. Yeah, I think yeah, I just thought that L5 was lateral calf and L4 was lateral thigh, but okay, yeah, this makes sense. Thank you.
Yeah, it's kind of in the weeds, and we don't usually have that many questions that are in the weeds, but because you guys were also learning this on the practicum, and a lot of people got it right, we stuck with it. All right. Okay. Well, I'm gonna switch over and we'll go through the slides here that you guys should have access to, but I'll pull them up here. Let's see. Okay. And I don't know what that was. Oh, hold on. Got it. Okay. Oh gosh, why is it showing me as I painfully talk about this? Do you guys see that it's annotating what I'm saying at the bottom? I don't know how to turn that off. Do you guys see what I'm talking about?
Yeah, we can see the annotation. I'm also trying to figure out how to turn it off.
It's okay, but maybe it's good for me. I see what I'm actually saying. Let's see.
If
I
it's
think it's
to
on
the
the
this
drop. Oh, sorry, you go.
if it's too distracting, maybe above like the mute button, if you hover over it, there's like the annotate circle that is
Above that. Oh, here we go. Annotate. Did that stop it? No. Is that the one you're talking about?
I think it's the button, the CC in the bottom left, that's orange.
Oh, got it. Got it. Okay. Thank you. I'll do that sometime and I'll have a better idea of how I sound. Okay, so I have thrown these together. They're kind of a combination of some questions and then pulling in slides that were from the lectures once we look at the answers to the questions. So these are not pretty. Usually I like my slides to look better, but I didn't have time to make them pretty. Okay, here we go. So now, so this is kind of picking up where we left off. On Wednesday, we had talked about, we were talking about the upper extremity, and I had gotten to the point where we were talking about some abnormalities of the upper extremity and joints. And so I just wanted to finish these last couple slides. So this will, in theory, be new content. And just want to make sure you're comfortable with these. Ganglion cyst is an abnormality that you'll see on the dorsum of the wrist, and it's usually due to, it says a cyst, it's a fluid-filled sac that's usually due to some sort of irritation, repetitive motion, and it tends to be kind of a dull pain or painless, and they tend to come and go on their own, and most of the time don't need any sort of intervention. But you can aspirate the fluid from the cyst. You can break the cyst. The way to indefinitely treat this is to remove the cyst wall or open up the cyst. So you can do that surgically, but most of the time, if you stop the repetitive motion, the cyst will resolve on its own. So just to be aware of what that is when you see a lump on the dorsum, and it also transilluminates because it is a cyst. So you can do a transillumination test on that. The next thing is just knowing the difference between rheumatoid arthritis and osteoarthritis. And they have some key findings that are helped to differentiate them from each other. Rheumatoid arthritis is a autoimmune inflammation of the synovial membranes. So any joints that have a synovial membrane, which is most of them, if not all, can be affected. Although you tend to see it more in the smaller joints, so wrists, hands, knee isn't necessarily a small joint, but definitely wrist, hands, and in the feet. And you will see that that inflammation will cause bone deformity. And the ones that you'll see most are going to be the deformities of the distal and the proximal interphalangeal joints. And we've already saw those in previous slides, but the swan neck and the boutonniere deformities, as well as ulnar deviation at the metacarpal phalangeal joints. You might also see some subcutaneous nodules. So this is going to go along with it's a systemic disease. So you'll often see other signs along with this, like weakness, fatigue, weight loss, sometimes low-grade fever when it's really flaring. And the involvement tends to be symmetric. So like you see in this second picture, with both hands affected, and it tends to be additive, meaning it starts to affect one joint and it doesn't ever go away in that joint, but now another joint hurts and now another joint hurts. And it tends to also be worse in the morning or after inactivity, which is also true with osteoarthritis. The other physical exam finding are these nodules, these subcutaneous nodules called Herbidens or Bouchard's nodes. Are they back here? Think I had found in rheumatoid arthritis. And so we want to contrast that to osteoarthritis. So rheumatoid arthritis was an inflammation of the synovial membrane. Osteoarthritis is a degenerative loss of cartilage. And because of that, because cartilage works as a cushion, now you have mechanical stress type damage on the bones where that cartilage is no longer doing its job. So you tend to see this a little bit more in the weight-bearing joints like knees, hips, but you can also see it in the hands. And its spread is also usually additive. It can involve one joint, but then in the next joint, because if you have damage to one joint, it's not going to get better. That cartilage is not going to grow back. So it's always going to be additive. It's not going to, come and go from a joint per se. Sometimes you can get effusions, sometimes morning stiffness, definitely decreased range of motion. And osteoarthritis is where you see Bouchard's and Herbidens nodes, which is basically the way that you describe kind of that swelling and some of the findings on the back of the hands. Did I just have them? Sorry, on the PIP and the DIP joints. Depending where the node is, it has a different name. So know the difference between the two. The PIP, the more proximal joint, is going to be your Bouchard node, and a node or a nodule on the distal interphalangeal joint is going to be called a Herbidens node. And for some reason on the pants, they really want you to know this, but it is a way to describe your exam findings. You could just say Herbidens nodes and on the left, and describe whatever fingers, and people would automatically know that it would be the DIP joint. This is just a comparison. Here's a normal joint. Osteoarthritis, you have a loss of cartilage, and that's caused the bones to be articulating on each other, and it can cause pain, it can cause deformity or formation of these bone spurs. And this slide compares all three of them. So this is showing the healthy joint as well as the healthy bone density. So when you think about rheumatoid arthritis, you still have the cartilage in there. There's still a space between the joints, but the inflammation is in the synovial membrane. With osteoporosis, which we weren't necessarily talking about, but that's just another bone condition, but you see a change in the density of the bones. And then with osteoarthritis, now you have bone on bone, no cartilage, but there's not necessarily inflammation. There's no redness or swelling. Well, sometimes you can have swelling with osteoarthritis, but usually it's more pain and range of motion limitations because of that bone on bone. So just the basic tenets of how those two are different and what are those specific exam findings for each. Another joint condition to know is gouty arthritis, which is also an inflammatory reaction to increased urate in the bloodstream that then doesn't get filtered out by the kidneys and then can end up in the joint spaces. And this one classically is just one joint. So whether it's usually the big toe joint, the MTP joint, so the metatarsal phalangeal joint. But you can also have pain in the instep of the feet, ankles, knees, elbows. So it can be anywhere, but classically it's that one big toe. And it tends to be sudden. And because it's due to an excess of uric acid, it's worse after like a high purine diet, which breaks down into urate. So excessive meat, or if somebody gets dehydrated or they have a lot of alcohol, which is also dehydrating. And it does tend to, it has this warm red mono articular issue. So one joint range of motion is limited because it's so warm and it's so painful. And then also you can have some systemic symptoms like a fever. And that's just kind of a picture there of what's happening. You got to have a buildup of uric acid crystals in the joint. And this is painful. And then the last, no, there's two more that I just wanted to touch on. One is polymyalgia rheumatica, which is also a autoimmune inflammatory condition. And the big way to differentiate this from other arthropathies are that it's in the big joints. So you see it more in the shoulders, the hip, sometimes the neck. And it's usually one joint, and also can have kind of everything else when you have an inflamed joint, swelling, decreased range of motion, and also can have the systemic symptoms, malaise, anorexia, weight loss, fever. So I kind of picture this woman who's having, it's really affecting the larger joints here. And most of these are worse in the morning. And then get better as the day goes on. So I think the big differentiating thing with polymyalgia rheumatica is it's going to have other symptoms along with the arthritis or the joint manifestations. You can also have muscle pain with it, and it tends to be the larger joints. And then the last one is ankylosing spondylitis, which is another autoimmune inflammatory disease that can affect a bunch of different places in the body in addition to the joints. And we'll get more into this next semester. But it can cause inflammation along the vertebrae, and it causes damage and such that you really lose your range of motion. It's called, sometimes you'll hear kind of like a bamboo spine read on an x-ray. And that's because this ligamentum flavum becomes it loses its laxity. It becomes very stiff. And so you can see that these people tend to be kind of hunched over, and it's because, and it can happen anywhere along the spine, but it generally ends up in some sort of kyphosis. And it's because the spines become it's lost its curvature. These are the key tenets. If you, 4 out of 5 of these have something like an 82% sensitivity for ankylosing spondylitis, but you want to think of it in somebody who's younger. So usually before 40, 45 years, with back pain. And the other thing that's different with this is that there's no improvement with rest, and there tends to be pain at night, and it feels better when you get up in the morning, which is the opposite of rheumatoid arthritis and osteoarthritis and polymyalgia rheumatica, where it tends to be that morning stiffness is the harder time and the most symptomatic time. So those were the conditions that I would focus in on. I know there's more in Bates, but these are ones that you're going to see again and again, because these conditions, you'll see them again when we're talking about more autoimmune type diseases, because most of them are autoimmune except for osteoarthritis, which is a degenerative type of abnormality. All right. Make sure I'm not missing. Okay. All right. Well, I'm going to jump into the review. I think I've got about 50 questions here. And they're not dissimilar from what you will see from the test. So this is kind of the level that I'm shooting for right now. Oops. All right. So what is a hinge joint? And give a few examples of a hinge joint. So a hinge joint is a synovial joint with a motion in one plane, like an interphalangeal joint or your elbow. And there are 3 different kinds of synovial joints. So just to know the basic function of each, and to be able to give a couple examples. So the spheroidal are going to be your ball and socket, hinge, and then the condylar, which are going to be 2 articulating joints. So just knowing the difference between those. And then we talked about 3 different main categories of joints. So we just talked about one, the synovial. Another kind is the sort of joint that you have with the intervertebral disc. And just to think about what are a few examples. So these are cartilaginous joints, and they have some movement, but less than the synovial, more than fibrous. These are things like the pubic symphysis or the facet joints in the spine. Those are cartilaginous joints. So then obviously I'm going to ask you, what is an example of a fibrous joint? And those are going to be joints with really immovable cartilage, like the suture lines between your skull bones, kind of the radius and the ulna. They really, there is a small amount of movement there, but it's very subtle. So those are your 3 main kinds of joints. And your tooth socket is also an example. So I'm just going to keep going, but feel free to chime in. There's questions. Oh, I guess I'm still talking about joints. This ball and socket joint is the most movable joint in the body. And how would you categorize it based on fibrous, cartilaginous, synovial? And that's going to be your shoulder joint, which is a synovial spheroidal joint. All right. These don't necessarily go in any specific order, based on body systems. So it's kind of like your chest. You got to kind of think all over the place. So what tests can help detect a medial and or lateral meniscus injury? So this just goes to kind of your special tests. A lot of these test questions you're going to know the answer to because you will have done your practicum and you will know how to do these and kind of what they're showing you. But essentially the McMurray sign can help you assess for medial or lateral meniscal tear. And the positive sign is crepitus with knee flexion extension or locking. If that cartilage is getting out of place when you do a range of motion, you can appreciate, sometimes you can appreciate that. So what would be a test would help you diagnose a PCL injury? And that would be your posterior drawer test. And just as a reminder of where the posterior cruciate ligament is, it's one of your key stabilizing ligaments in the back of the knee. So just knowing basic mechanism of injury is also important. I know a lot of these knee ones can happen with, can happen in different ways, and the mechanism of injury wouldn't be the only piece of information you would be given. But with the anterior and posterior cruciate ligaments, it does tend to be more of sort of like an anterior blow to the tibia or a posterior blow. It tends to be something that's a little bit more in the anterior posterior plane, but it can be a twisting injury as well. So mechanism of injury won't be the only piece of information you'll get, which would be the situation with your patient you're seeing in clinic as well. You wouldn't, but it's just one of the pieces of information. But just correlate the posterior cruciate ligament tear with a positive posterior drawer test, and then same with anterior cruciate with an anterior drawer test. What tests can help you diagnose major and minor effusions? Those are going to be your bulge and your balloon tests. The bulge test being the one where it's a smaller effusion, so you're kind of milking fluid out of the suprapatellar pouch and putting some pressure on the medial side of the knee so that you're basically pushing all the fluid over to the lateral side of the knee, and then you're kind of looking, does that area become more full? Do you notice, you know, when you push on it, does it feel like there's fluid under there? Where the balloon test is a different way to check for that. Here's your bulge test, which I just talked about. The balloon test, you're more so putting pressure on the upper and lower part, like the suprapatellar pouch, and then up from the tibia. And it's kind of similar to the Blotman test, where you've got all the fluid in there and then you push on the patella and see if there's kind of any bobbing or fluid there. So just two different ways to assess for an effusion. Okay. You suspect an injury where there is softening and breakdown of the cartilage under the patella. Which test do you check? And what injury or abnormality are you suspecting? What does that describe? Softening and breakdown of the cartilage under the patella. So the condition is chondromalacia, and the test that you would use is the patelliformal grind test, which there's a couple ways to do this. You can either, with the patient in the flexed position, you can hold on the patella and have them contract their quads, and which will, you know, pull up on the patella kind of and create pressure under there, and see if that causes kind of like a crepitus. Sometimes it'll cause pain, where you can just, in the flex position, you can kind of push on the patella and again, see if you can recreate kind of the crepitus under there, which is the cartilage that is no longer smooth. It's kind of crunchy and irregular. So just being able to connect those when you think about knee pain that's on the front of the knee. There's a handful of different structures on the front of the knee. You know, there's the patellar tendon, there's the tibial tuberosity. So but when you're thinking of pain that's in the middle of the knee, you know, the obvious place is to focus in on the patella. What if there's pain on the medial side of the knee? Then you kind of think, is it along the joint line? That might be more of a meniscal issue. Is it on the like medial, on the complete medial side of the knee? You might think medial collateral ligament. If it's down below the tibial plateau on the medial side, you might think the pes anserine bursa. So just knowing the different structures around the knee. So if you have pain, describing pain in different areas or symptoms in different areas, you're familiar with the anatomy that's there, and that often will help you figure out the problem. All right. So a patient sustained a blow to the outside of the right knee while his foot was planted, and you're concerned for a collateral ligament tear. This test would help you with your diagnosis. So for your lateral and collateral ligaments, you want to think about the valgus or varus stress tests. So if it's the medial collateral, you'd want to do the valgus stress test. So put a valgus force, which you would be looking for kind of laxity or instability on the medial part of the knee. And then if you're thinking of a lateral collateral ligament injury, then you would want to put varus stress. And so any scenarios are going to give you kind of mechanism of injury, other physical exam findings, or they might kind of tell you what it is and what test would be the most helpful. So this is just a summary slide of all those different tests and kind of correlating them to what condition you're trying to diagnose. All right. So we just talked about this. What is a Bouchard's node and where are they found? And what chronic condition is it associated with? So that's going to be osteoarthritis, which is going to be that progressive loss of joint cartilage. And the Bouchards are the proximal interphalangeal joints, where Herbedens are your distal. So just figure out a way to remember those two. But those are going to be signs of osteoarthritis. Okay, a patient presents to your clinic with a tender lump on the dorsum of her wrist. She works on a computer all day. What is this abnormality? And we just talked about this as well. If you're just given that much information, I mean, generally you'll be given more than that, but this would be a ganglion cyst, which we just talked about at the beginning of class. All right. A patient with a history of arthritis thinks she's grown another kneecap because she's got a lump behind her knee. What is this? So when you think of conditions behind the knee, you'll think of a popliteal cyst or a Baker's cyst, which is just another pocket of synovial fluid that's at the back of the knee. You can also think of like a PCL injury would probably be the other main thing that would cause pain in the back of the knee. All right. Okay, lumps under the skin or within joints that are a buildup of uric acid crystals. So what is that condition? And that's going to be your gouty arthritis, which again is an inflammatory reaction to those crystals. Tends to be one joint, often the big toe. It tends to be a sudden onset, can have systemic symptoms like fever, and you're going to have a red, warm, tender joint with a poor range of motion due to pain. Okay, valgus or varus? So what are you trying to think of when, what are you trying to think of? Sorry, this is poorly written. So how do you describe knock knees? What's a different way of describing knock knees? So that's going to be varus, or sorry, valgus. Let me go to here. A lateral collateral ligament injury is usually due to what kind of stress on the joint? So that'll be varus, a blow from medial side of the knee. Knee test, which helps to diagnose medial collateral ligament injuries, puts what kind of stress on the knee, which will be a valgus stress or stress from the outside. A cowboy might look like he has this kind of leg malalignment, which is kind of like bow-legged, and that would be a varus malalignment. And during a wrestling match, this kind of stress on a patient's knee has resulted in a lateral collateral ligament and lateral meniscal injury. And the kind of stress would have been a varus stress. So just knowing kind of when to use the terms, whether they're describing a malalignment or a certain force. So just to make sure you got those two straight. All right, just some more random questions. Talking a little bit now about the spine. So an extensive concavity of the lower spine is called lordosis. I'll just go here. Spontaneous anterior posterior vertebral slippage resulting in a step off is going to be the spondylolisthesis. And I sent you guys an email a little bit more about spondylolisthesis because it doesn't necessarily have to do with a fracture. It can be just a slippage on its own. There's a bunch of different reasons why it can happen. It can happen because your vertebral discs get worn down. It can happen because of trauma. It can happen because of infection. But just the key point is it's an anterior slippage, and you're going to pick up on that when you're doing your palpation along the spinous process. You're going to feel an area where it doesn't seem in alignment or a step off is what that's referred to.
I just had a quick question.
Yeah.
So it would be anterior or posterior slippage. So does that mean when we are palpating for step off, that would we would be able to feel more of the bone, or we would feel a dip?
It depends. I think that it's more often an anterior slippage. If it's anterior, then you would feel less, right? Because that spinous process is going to be pushed forward. If it was posterior, then you would feel almost like a bump sticking out, and then you would go back down. I think it's more anterior than posterior.
Okay, thank you.
Just based on the ligaments. I think it has a little bit different to do with male and female as well, and kind of estrogen levels affects how the laxity of the ligaments, the ligamentum flavum. And then the progressive loss of joint cartilage can cause joint inflammation throughout the body, and that's going to be describing osteoarthritis. Or if it said a inflammatory joint condition affecting the large joints, shoulders and hips, think of polymyalgia rheumatica, just kind of the different differentiating factors between those couple of conditions. All right, we're going to move on to the ankle. So the anterior drawer test or the talar tilt test can help diagnose this ankle inversion injury. So the two big ones to know are the inversion and eversion injuries, and which ligaments they're going to largely affect. So the inversion injury is going to affect the lateral ankle, and most often it's that anterior taliofibular ligament is the one, something like 90% of the time it gets affected, because that's this guy right here. especially if your plantar flexed and invert. And then here's your anterior drawer test. So it's very similar to the posterior drawer test. You're stabilizing above the ankle and then pulling forward to see if there's any laxity. With the talar tilt, you're basically inverting and everting the ankle and comparing between two ankles and seeing if there's increased laxity on the side where you have the injury. Both of these, if you can imagine, with any joint exam, those first few days when there's a lot of inflammation, that might not be a very helpful test. These are more helpful, 4 to 5 days after an injury or after, where the pain and the swelling has cooled down a little bit. Okay. What's the name of the ligaments on the medial ankle? Anyone?
Deltoid.
Yeah, deltoid complex. That's an easy one to remember. All right. A positive Apley scratch test can help to diagnose this disease caused by immobility. And that's going to be adhesive capsulitis, which usually happens when the shoulder joint has not been used. So you see it often after an injury or surgery where that arm is just kind of protected and it doesn't get its range of motion back. And the Apley scratch test helps you, essentially you're checking the inversion and the eversion by reaching over, and inversion by reaching back. And like Professor Newhouse said, you can sort of measure how flexible they are on the level of, or you can document it based on the level of how, of what level vertebrae their finger reaches up to. But basically, Apley scratch test can be used for inversion or eversion in general, but definitely is used with diagnosing adhesive capsulitis. All right, moving on. A few other questions. Oh, so these are famous orthopedic doctors, I'm assuming, because these are going to all be tests that have somebody's name attached to them. So this test involving tapping the underside of the wrist can help diagnose a problem with the median nerve. So that's going to be Tunnel's, which you can do Tunnel's test, in many different areas. Oh, geez, that hurt. It's just mostly that tapping motion is going to be a Tunnel's. You can do it in the elbow as well, back here, for the ulnar nerve. Squeezing the gastrocnemius and soleus calf muscles will not result in plantar flexion of this if this test is positive. And that's going to be your Thompson test for a Achilles rupture. And this test assesses for impingement of the supraspinatus muscle. Sorry, that's tendon. That is not written out quite right. And there's actually two tests that could be the answer to the Neers or the Hawkins. So you're going to know all this after your practicum, because this is what you guys are going to be showing us on Monday. So here's some more famous orthopedic doctors. You are able to reproduce your patient's neck pain and left-sided arm paresthesias with this test to confirm cervical radiculopathy. That's going to be your Sperling's test, where you're going to have them tilt their head kind of toward the side where they're having the symptoms, and you put a soft axial load. And then in this next one, in this test, a patient is asked to hold out their elbow at 90 degrees, tuck their thumb into their closed fist, and then ulnar deviate. This reproduces pain at the lateral base of the thumb, and it's a positive test for de Quervain's tenosynovitis, and that's Finkelstein's test. All right, moving right along. The space in the vertebrae is where the spinal cord travels. That's called the vertebral foramen. How about where the peripheral or where the nerve roots travel? That would be your intervertebral foramen. So just kind of know the basics of the vertebrae anatomy. So we're going to talk a little bit more about some spine issues. Patient lifted a 50-pound dog and now has shooting pain down his left leg, positive straight leg test, weak knee extension, and decreased patellar reflexes on the left side. What is his diagnosis? So that's suggestive of a radicular back pain because it's one-sided. Given the information you have, assume that it's one-sided, and that's going to be radicular back pain or sciatica. And just remember, it's usually at the L4, L5, or S1 roots. And if it also causes any dysfunction with the saddle anesthesia, bowel or bladder dysfunction, then think of quad equina syndrome.
Professor?
Yeah.
I have a quick question. So the cause of the paresthesia or cause of the shooting pain down his leg is caused by sciatica, but is the sciatica caused by a herniation?
You don't know in this example, but usually an acute issue like this is a disc herniation.
Okay.
Mhm.
Got it. Thanks.
Yeah, if it was more insidious or it had other symptoms with it, then you might think, and you would want to rule out with something like this, is this like a musculoskeletal strain, but the straight leg test and the nerve, reflex findings kind of tell you that it's more involved than muscular. So yeah, most of the time this would be due to a herniated disc when it's
Question, Professor.
Yeah.
Would a disc herniation not show bilateral symptoms, or is
Yeah.
it more unilateral?
as I'm looking at this, I'm like, this looks more like this is more lower motor neuron, decreased patellar reflexes. What do you guys think? Weak knee extension makes sense, but decreased patellar reflexes, that would tell me it was more central. Decreased on the left side. That to me sounds more like nerve root. I think if you had a test question like this, it wouldn't as much probably be asking you to differentiate between like a myopathy versus a radiculopathy. Like, is this central cord compression versus nerve root? But we should know this from our neurology that we just did. Let me think about this a little bit more. What was your thought, Jeet?
Well, I was thinking more upper motor neurons, potentially.
Right. With this slide and with cauda equina, that would be a cord compression. This question it's a one-sided symptoms. Technically radiculopathy is I thought nerve root. I'm pretty sure that's what Bath says. Let me look really quick. Let's see. I think the part that's confusing, and I don't know that I have a good answer for you, is cervical radiculopathy. In Bates is described as nerve root compression, where cervical myopathy is more cervical root compression, but then on low back pain, they call sciatica radicular. Let me look at something really quick. Which sciatic pain is usually disc herniation. This terminology isn't used in the test, myopathy versus radiculopathy, so I don't think that will confuse you. The difference between unilateral or bilateral symptoms is often the difference between, whether it's nerve root or something more central, which show bilateral symptoms, like cauda equina, whereas nerve root would just show unilateral symptoms, either of which could be caused by a herniated disc. So I'm afraid this question has only now caused confusion for you all. But I think the takeaway point is that kind of the difference between whether it's bilateral or unilateral symptoms, and kind of the mechanism of injury, and considering that disc herniation is going to be the cause of most acute back pains that have a mechanism, acute back pain that has a mechanism of injury, of some sort of, heavy lifting or such. Did I just confuse everybody now? Yeah, I think the takeaway point with this question is that it's unilateral. There's a positive straight leg test, and the mechanism of injury was acute, with an otherwise probably healthy-ish person. We don't have an age here, I was thinking they were 50 years old, but acute unilateral positive straight leg test, you would be leaning toward herniated disc and a sciatica. But if it was bilateral, that's going to be a cord compression, and that's where you get into the cauda equina. Okay. So let's look at another back pain. So Frederick is a 79-year-old male with progressive back pain that is getting slowly worse. He also complains of poor appetite and weight loss. He denies any sciatica, leg weakness, joint tenderness. So what is your differential diagnosis with somebody like this? This is where you would want to broaden that a little bit, because it also gives you an older age group. It's a slow problem. He's got some other systemic symptoms going along with it. And he doesn't really have any signs of any sort of nerve root compression or central cord compression. So that's where you want to, at that point, think about other both MSK related diagnoses and non-MSK related diagnoses. So some MSK related would be malignancy. If it was like a bone malignancy, low back strain, or lumbar stenosis. This is the kind of guy that could get a spondylolisthesis, where he just, as you age, you can have slippage of the vertebrae. But you might expect more nerve pain, kind of nerve root symptoms. And then you also want to think of your non-MSK etiologies. Is there anything else going on? These autoimmune diseases we just talked about, or is there something else in the body that's causing a problem? But you would get more information about that if that was the case. But given this amount of information, I would be thinking probably malignancy, or just some sort of just, you would want to widen your differential diagnosis. We're not going to ask you for differential diagnosis on this test, but I just want you to think about what are these other MSK related diagnoses or the non-MSK related.
Question, Professor.
Yeah.
For those specific symptoms, could it be degenerative disc disorder or could it be something else
Could
potentially?
be. Yeah, and that's the kind of tricky thing about an older person where, you know, he could definitely, this could be just kind of some osteoarthritis going on, just wear and tear, some degenerative joint disease. But I think you would be in his age group, it'd be a disservice if you just kind of said, I think it's degenerative joint disease. You'd at least want to do some sort of workup. Well, let's confirm that on X-ray, you know, kind of dig a little bit deeper into what's going on in somebody like that. But you're right, it could just be, it could be something that, you know, is not a concern, but it just want to be thinking of outside the box on somebody like that. Lumbar stenosis, I'm not sure we're going to talk about that again. So remember, that can be another cause of back pain anywhere along the spine. It's more often cervical and lumbar. That's where your vertebral foramen is getting more narrow, which can just be naturally occur because of aging. It can occur because of a bulging disc going into the foramen. But the key thing with this is that usually it doesn't have radicular symptoms. It doesn't have like cord compression, nerve root symptoms, aside from kind of general pain. And it's called neurogenic claudication. So kind of pain and fatigue. And it gets better when that vertebral column is not as compressed. So it's often positional. It's often better when you're bending over, and worse in lumbar extension. And this you tend to see in an older population because they're the ones that are going to have those changes with aging. But if it is a disc issue, then you could see it in you know, a younger person.
Oh, I have a question. For lumbar stenosis, can the pain radiate down or is it just localized in one area?
I believe it's the classic is that it's not a true like cord or nerve root compression, but let me double check that for you, Pollock. Let me double check and I'll email you guys.
Okay, thank you.
All right. What kind of fracture creates a posterior dislocation of the elbow joint? So remember this picture that this image looks like a posterior dislocation. Well, it is, but this also can look the same way when you're examining a patient, but it could represent a subcondylar fracture. And that's something that you'd probably differentiate based on the mechanism of injury as well as your X-ray. What carpal bone next to the radius is often injured when a person falls on an outstretched hand? And then this can result in tenderness of what structure of the dorsal surface of the hand? So that's going to be your scaphoid or navicular fracture. And here's your radius, and the scaphoid is sitting right above that. And then your anatomic snuff box, which is right here, is where you may have point tenderness. You know, beyond that, I wouldn't get into the details of memorizing the carpal bones. I feel like they're going to want you to know that on the pants, but I don't feel like that's something that anybody needs to know off the top of their head. Okay, back to the hand abnormalities. Persistent flexion of the PIP joint with hyperextension of the DIP can be seen in patients with rheumatoid arthritis. How would you describe this abnormality? So that's going to be your boutonniere deformity. So flexion of the PIP with hyperextension of the DIP. Where your swan neck is going to be the hyperextension of the PIP with flexion of the DIP. So just to know the difference between what those are. A patient presents with tenderness at the tip of her thumb after a puncture injury. She's got localized tenderness distal to the PIP, erythema swelling. What is your diagnosis? And that's going to be a felon, and that's an abscess, which you would probably need to treat with incision and drainage. But it's just important to differentiate between paronychia, which would be a inflammation around the nail bed. And these tend to be really painful because there's swelling, and with an abscess, there's usually some sort of pocket of infected fluid that's trapped underneath there, and that pressure can be very painful. All right, what are the 4 muscles that make up the rotator cuff, and what is each of their functions? So just to be aware of what these are called, what they do, and when you're doing the shoulder special test, which muscles you're testing. I just made a little change in this slide. The supraspinatus elevates the humerus, but I would think of that more as abducting it. So this motion. And for spinatus, external rotation, as well as the teres minor, and then subscapularis is internal rotation. So a patient has ongoing left shoulder pain worsening when reaching up high to water her plants. At times it feels like it's catching or grinding. Neers and Hawkins tests are positive, and your drop arm test is negative. So you want to think of what's going on underneath that AC or the coracoidocromial ligament. And that's usually going to be some sort of tendinitis or impingement of that supraspinatus tendon. And the mechanism of injury is usually repetitive overhead motion. And then the symptoms of kind of that catching, if that tendon is irritated, it's not going to be smoothly articulating. So that's why you get the catching and pain and maybe grating. And sometimes weakness as well. But technically a drop arm test, I think within a drop arm test in real life, you say, with weakness can be a positive drop arm test, or you would say weakness with drop arm test. But for this test, just think of a positive drop arm test as being a tendon tear. So for this patient, because it was a negative drop arm test, that would be, you would want to think more about tendinitis, as well as the Neers and the Hawkins, because those are both impingement tests. Okay. When asked to adduct his arms across his chest, your patient had a sharp pain in the front of his shoulder. What joint do you suspect? This one we didn't have a slide about earlier, but it's on your practicum list. And this is the crossover test. So the acromioclavicular joint crossover test. So when you're adducting your arm across, you're making that joint smaller. And if somebody has AC joint tenderness, that'll make it worse. So that's called a crossover test, and it's on your sheet here. Billy has ongoing right shoulder pain interrupting his sleep, with grating, catching, worse when he's reaching overhead. Drop arm test is positive for weakness. So that's going to be a rotator cuff tear. Tear doesn't always mean that the entire tendon has been disrupted. It could just be part of it, and that's where you get the weakness rather than a complete loss of control with a positive drop arm test. Right. Remember your neurovascular exam is a way to, and kind of what nerves innervate what part of your hand. So do you think of radial nerve, median nerve, and then spreading apart the fourth and fifth finger are going to be your ulnar nerve. And then your sensory is you just knowing those three different distributions if you did a sensory exam, and then perfusion is capillary refill. I'm not sure why I threw that in there. Never mind. Oh, you know, we aren't going to get into, this is more tophaceous gout, which is like when you have chronic gout, you just start to develop these extra nodules called tophi, but we're not going to get into that quite yet. Okay, abnormal gaits. So just remember the different gaits and what they look like. Trendelenburg is that due to the abductor weakness, and you have sort of that waddling gait. Vaulting is when you can't, usually because you can't flex your knee, and so that you're on the foot during the stance gait, you tend to vault up onto your toes to make that hurt leg be able to swing through. And then circumduction is when you also can't have a normal swing gait, and you're sort of moving your leg around. So just be aware of those. So if you have patients like that, you can describe their gait. There's the Trendelenburg, which is that kind of waddling gait. We are not really doing this test on the practicum, but just to be aware that this is one of your tests for groin strain. It's easy to remember because of it's called a Faber test, Faber, and that's kind of stands for flexion, abduction, and external rotation. You can see the examiner at the top here is pushing down, and if there was a groin strain that would give you a pain back in the area of the strain. I feel like we've gone through a lot of these. Yeah, sorry, I feel like some of these are repetitive. I'm going to move ahead to this bursitis. So just remember where, do you guys want to go through these knee things? I feel like we've done a lot with the knee. Anyone? How are we on time? Okay, let's skip this knee stuff. I feel like we've done a lot of knee. We reviewed it before too. Okay, so just remember the bursas that are here when you're thinking about anterior knee pain, the site of the pain and the mechanism of injury can give you an idea of whether it's a bursa, which tends to be more of a repetitive motion type injury, but can happen with arthritis as well. Ankle sprains, we already talked about. Yeah, so there's more slides here to just kind of keep practicing. This is the only other one I don't think we've talked about was Dupuytren's contracture, which is fibrosis or tightening of the fascia underneath the hand. And it's usually between the fourth and fifth finger, and it's can be hereditary, or you see it in people who smoke or who are have a diabetic or alcoholic background.
Professor Wallen,
Mhm.
sorry to go back, but for the rheumatoid arthritis versus osteoarthritis, do the nodules present the same? Like, unless you differentiate with like systemic symptoms?
Well, know that the nodules for rheumatoid arthritis are going to be your swan neck, or sorry, or your abnormalities. Sorry, they can be anywhere on the hand. Is that what you were?
Yeah, are the nodules, they appear the same though for both arthritis?
No, with osteo, I think you're just getting, I don't think you're getting them on the metatarsal phalangeal. I think it's just gonna be on the PIP and the DIP, where with rheumatoid arthritis, they're gonna be more, I mean, they can be all over the hands. It's not like, just on the joint. Here it's along the tendon.
Thank you.
And I'll email you guys about that. And otherwise, I'm gonna see some of you over in the lab in a few minutes. To go over, see if there's any last questions on that, since we didn't have a lot of time to practice. Make sure you're comfortable with that.